And so next up, I would like to introduce Professor Tony Skapetis, and I hope I pronounced your name correctly, Chair of the Western Sydney Local Health District Human Research Ethics Committee, who's going to talk about COVID-19 bioethics and tell us all we need to know about that in 15 minutes. Good luck.
Thank you very much, Hudson. And guys, sorry, I do have to still wear a mask and things, and I am a dentist as well, but it's not that I don't want to show you my face, it's just that the clinical area I'm in, I just have to do this. So I apologize if the sound isn't so clear. Now, before I start, I also just want to acknowledge the traditional owners and custodians of the land of which each of us are on at the moment, and pay my respects to elders past, present, and emerging. Now, this talk is largely based on a recent publication, and it's in BMC Medical Ethics. And I do want to pay my acknowledge my co-authors, Doctors Constance Law and Rohan Rodrigues, for their assistance in the paper as well. So I'll try to give you a bit of an outline of some of the things that we came across when we were writing this paper. Now, most of COVID research ethics conversations seem to be focused around high prevalence countries, and Australia, we've been very fortunate in general. A lot of the states, if not the majority, have shown a general low prevalence. So the songs and tunes we have in association with research ethics around COVID in Australia are quite different. Some of the considerations, the ethical considerations and the themes that are generally out there include equity, individual liberty, privacy and confidentiality, proportionality, public protection, provision of care, reciprocity, as well as trust. And we'll talk about each of those themes a little bit and give you some examples where the low prevalence experience of conducting research in COVID in a low prevalence environment shows quite some significant differences in those dimensions compared to the higher prevalence countries. So if we start with equity, first of all, and I'm going to talk about equity here in terms of collaborations. In the high prevalence countries, they were inundated with COVID research proposals, and that, of course, is associated with a large amount of funding that followed. On the other hand, Australia having quite a low prevalence, well, why would anybody want to do research in a country where there's no COVID? So that was an interesting experience that was quite specific in terms of that dimension, that ethical dimension in low prevalence. If we look at individual liberty, meaning participation and the individual yes/no ability to participate in COVID research, when we have Australia with the low general prevalence, we had quite a disproportionate burden on just a few COVID positive patients to participate in clinical studies, whereas that, of course, was not an issue when you had hundreds, if not thousands, of COVID positive patients, as in the higher prevalence countries. Privacy and confidentiality, well, that becomes a bit of an issue too with low prevalence. For example, if you've got not only 4 people who are COVID positive in ICU, for example, of which only 1 is male, how do you maintain confidentiality? It becomes rather difficult. Now, proportionality as a theme, what happens there? It takes a slightly different dimension as well with low prevalence. With our very strict or more strict public health measures in order to protect the public, which of course we're very thankful for during the pandemic, it also managed to inadvertently suspend many of the clinical trials, which would potentially be very beneficial to patients. So that idea of proportionality it certainly needs to be reconsidered. Public protection as a theme, well, clinical trials were redirected largely in Australia with a lower prevalence away from hospitals and towards the communities. So therefore, protocol compliance, monitoring, all those may potentially have suffered, which was quite unique. Provision of care, lower numbers of COVID patients within our hospitals led to possibly oversampling of these patients. So imagine you've got half a dozen COVID positive patients in ICU. The infectious diseases people want to take some bloods, conduct their studies. The cardiology people want to take bloods, conduct their studies. The various other groups want to do their studies. None of these talk to each other, often all competing against one another. And it's interesting to see that in Australia, we actually don't have any maximum blood draw guidelines for research. And that applies to both adults as well as children. And that's quite interesting, given that for most countries, they do have maximum blood draw guidelines for research. Reciprocity is a theme. If we think about it in terms of redeployment and worker satisfaction, in the high prevalence countries, people were redeployed and asked to do things well above usually their scope of practice. But that brought a bit of apprehension, but also brought a lot of self-satisfaction because they were doing something very useful and what they could feel was very contributing to the COVID pandemic. On the other hand, we redeployed quite a lot of people because we didn't know how bad the situation was going to be. Luckily, it wasn't as bad as we thought in a lot of places. And suddenly those redeployed people were probably underutilized and they felt somewhat deflated because of their skills certainly weren't being used as much. Now, I don't want to end with too many negatives, but let's look at a positive and another dimension of trust. And how is that different in low prevalence? Well, in Australia, when you've got quite a lot of competing groups, but with low prevalence, with these research groups, you've got low numbers, and those low numbers means that the research groups had to collaborate, whether they liked it or not, and that was actually a good thing. In the higher prevalence countries, that was quite different, of course, lots of numbers of COVID positive patients. There wasn't the necessity to collaborate. Of course, there was the competing interests of who wants to get their research out there first. So, Hudson, I think I'm on time, and I'll let you catch up, you see. So I'm happy to take any questions though.
Do we have any? Seeing none, thank you, Tony.
Thank you very much.